In this video, I will be discussing the physical diagnosis of thyroid disease. The learning objectives will be first, to be able to demonstrate the general approach to the examination of the thyroid. Second, to be able to describe potential abnormalities of the thyroid on physical exam. And last, to list other common physical findings in thyroid disease. The thyroid exam tends to be one of the more difficult exams for trainees to learn well because the thyroid gland is relatively subtle in most people, preventing the immediate confirmation of correct technique. The key to a good thyroid exam is knowing the relevant landmarks. So I'll start by describing normal neck anatomy as it relates to the thyroid. The thyroid is a midline structure located in the mid-neck. It has a right and left lobe joined by a narrow isthmus. It has a close and relatively consistent relationship to other structures. Moving from superior to inferior, there is first the hyoid bone, which is not usually palpable in the midline. Next is the thyrohyoid membrane, also non-palpable. And then the thyroid cartilage, which is the most prominent landmark in the neck, and what is referred to by laypeople as the Adam's apple. Immediately below the thyroid cartilage is the cricothyroid ligament or membrane, which is the location of cricothyrotomies, a procedure rarely used to obtain an emergent airway in situations of upper airway obstruction. Then moving downward is the cricoid cartilage, which is also palpable, but not as prominent as the thyroid cartilage. And below the cricoid cartilage, just anterior to the second and third tracheal rings, is where the isthmus of the thyroid is most commonly located, with the two lobes extending outward laterally. The gland wraps itself around the anterior and lateral aspects of the larynx and upper trachea. It may have occurred to you already that these structures are poorly named, as it's misleading for the thyroid cartilage to not be the one actually adjacent to the thyroid gland, but unfortunately these are the names with which we are currently stuck. So how do we actually examine the thyroid gland in a patient? As with any part of an exam, the first thing to do is inspection. On occasion, a patient may have an obvious enlarged thyroid, which is called a goiter, that is grossly visible. However, most findings discovered in the thyroid exam are with palpation. Palpation can be performed from two different approaches: the anterior approach, in which the examiner stands directly in front of the patient, or the posterior approach, in which the examiner is behind the patient and literally wraps his or her hands around the neck. From the patient's perspective, the anterior approach is presumably preferred by most, although some clinicians feel that the posterior approach increases sensitivity for finding subtle abnormalities. How an individual clinician weighs these two concerns is a matter of personal preference. Begin palpation with a finger on the patient's chin and slowly slide it down the midline over the non-palpable hyoid bone and thyrohyoid membrane. The first significant palpable structure will be the laryngeal prominence of the thyroid cartilage. Keep following this downward until the finger slips into a small horizontal groove. This represents the location of the cricothyroid ligament. The cricoid cartilage is the firm structure immediately below the groove, and the thyroid isthmus should normally be just inferior to that, although it's not always clearly palpable. But once there, slide your fingers to either side of the midline, and you should be able to feel the two lobes. With gentle pressure, roll your fingers over the lobes. Some clinicians prefer using the thumb on one side and the second and third finger on the other. Some clinicians instead prefer using the two thumbs, and others prefer using the first and second fingers on each hand. I don't know if any of these three is necessarily superior to the others. What's far more important is correctly identifying the landmarks, and thus ensuring that you palpate in the correct location. In the event that you think you may have found a nodule or mass, but aren't sure if it's within the thyroid or if it's within a more superficial structure, you can ask the patient to swallow. As the thyroid is tethered to the swallowing apparatus, it rises when the patient swallows, and so should a thyroid nodule. If it fails to rise, it indicates the nodule is in the subcutaneous tissue. Although they are most commonly located well above the normal location of the thyroid gland, thyroglossal cysts can occasionally be mistaken for thyroid nodules. These can be distinguished from the latter by asking the patient to stick out the tongue as far as it will go. Thyroglossal cysts will rise up with this action, whereas thyroid nodules should not move. So as you are doing the thyroid exam, exactly what types of abnormalities should you be observing for? First, I already mentioned a goiter, also known as thyroimegaly, which is simply an enlarged thyroid gland. Some goiters will be very obvious just on simple inspection of the neck, as seen here with a relatively modest goiter, and a substantially more prominent one. Other goiters will require careful palpation. Rarely, a goiter will grow downward into the chest rather than upwards and outwards within the neck. These substernal goiters are more problematic since they are more likely to compress adjacent structures, such as the trachea, esophagus, and great vessels. Typical symptoms of a substernal goiter include frequent coughing, the sensation of food getting stuck in the throat when swallowing, and difficulty breathing while supine. Each of these symptoms are more commonly caused by other conditions, making a substernal goiter particularly difficult to identify. A dramatic eponymous physical finding of a substernal goiter is called Pemberton sign. In this finding, when a patient with such a goiter raises his or her arms over the head and holds them there for a minute or so, the face becomes red or occasionally cyanotic, with a sharp demarcation in the neck. The patient may feel fullness of the face or have an unusual sensation in the head, but they are not typically dyspneic or dizzy. There are competing hypotheses about the precise mechanism of this finding, but all involve extrinsic compression of the great vessels against the enlarged thyroid, resulting in venous congestion of the head. It can also be observed in patients with SVC syndrome. Another exam finding already mentioned are thyroid nodules. One should indicate the number of nodules as well as size and location of each, and whether or not it is mobile. Tenderness of the thyroid gland can occur in the setting of severe inflammation. And the last finding which one should check within the thyroid itself is to listen for a thyroid bruit with your stethoscope applied over the thyroid gland. Thyroid bruits typically indicate hyperthyroidism and are most commonly described in Graves' disease, though they are not highly specific for that particular condition. I personally don't typically bother listening for a thyroid bruit unless I'm specifically concerned about the possibility of hyperthyroidism based on history and other exam findings. Something that is important to realize about identifying a goiter is that its presence tells you very little about actual thyroid function on its own, as goiters may be present in patients who are hypothyroid, hyperthyroid, or even on occasion euthyroid. Consider the following chart of common causes of goiters. Patients with iodine deficiency are typically hypothyroid. Those with multinodular goiter can be either euthyroid or hyperthyroid. Hashimoto's thyroiditis is usually hypothyroid. Graves' disease is hyperthyroid. Patients with subacute thyroiditis can have any clinical thyroid status, depending upon what stage of the illness they are currently in, although the hypo and hyperthyroid stages both tend to be relatively mild and short-lived. And lastly, goiters can be caused by infiltrative diseases such as amyloidosis and sarcoidosis, which can be either euthyroid or hypothyroid. So you can see that the fact that someone has a goiter tells you actually very little about the specific diagnosis or even what their thyroid status is. Before we move from this chart, I just want to point out that iodine deficiency is the most common etiology of goiter worldwide, while goiters in the US are typically caused by either multinodular goiter, Hashimoto's thyroiditis, or Graves' disease. And although subacute thyroiditis doesn't necessarily lead to an obvious goiter in all cases, it is the most common etiology of a tender goiter when one exists. An aspect of the physical diagnosis of thyroid disease that may not be immediately apparent is that the most diagnostically helpful signs are physically removed from the thyroid gland. As thyroid hormone has an extremely diverse range of normal actions in the body, both hypo and hyperthyroidism cause an equally diverse range of exam abnormalities. Starting with hypothyroidism, in the cardiovascular system, bradycardia is common, and in extreme cases, patients may be hypotensive. Regarding the dermatologic exam, their skin is often cool and dry, with coarse hair, brittle nails, and rarely a yellowish discoloration to the skin. This discoloration is thought to be secondary to decreased conversion of beta-carotene to retinol, with subsequent hypercarotenemia. Hypothyroid patients frequently have neurologic findings, specifically slow mentation, hypothyroid speech, which is characterized by slow, low-pitched, and occasionally slurred speech, which is partly a consequence of the deposition of mucinous material within the vocal cords, and hyporeflexia, which is associated with a prolonged relaxation phase of the ankle reflex. Two miscellaneous findings include hypothermia and non-pitting generalized edema, which is thought to be due to the accumulation of mucopolysaccharides in the subcutaneous tissue. This form of edema is occasionally called myxedema, which is similar to, but not identical to, pretibial myxedema, which is actually more classically described in Graves' disease, an etiology of hyperthyroidism. And to add to the confusion, the term myxedema is occasionally used as an old-school synonym for hypothyroidism itself. In general, individual findings of hypothyroidism are more specific than sensitive. Thus, the presence of exam findings, particularly characteristic hypothyroid speech and coarse skin, argue for a diagnosis of hypothyroidism. However, there is no specific finding whose absence argues significantly against the diagnosis. It is certainly possible to be symptomatically hypothyroid without any physical exam abnormalities. Moving on to hyperthyroidism, it too has a large number of diverse findings. In the cardiovascular system, there is almost always tachycardia, which is usually sinus tachycardia, but is occasionally atrial fibrillation. Patients are frequently hypertensive, and they may have a flow murmur on account of increased myocardial contractility. The skin is frequently warm and moist, and hair is fine and abundant. The neurologic exam is frequently abnormal. Patients can exhibit psychomotor hyperactivity, which is also known as hyperkinesia. They can have pressured speech, a fine tremor, proximal muscle weakness, and generalized hyperreflexia. There are also several distinctive eye findings, such as lid retraction and lid lag. These are variations on the same phenomenon. In lid retraction, the patient has an unusual staring appearance caused by a widened palpebral fissure, that is, there is more than normal space between the upper and lower eyelids. In lid lag, the eyes appear normal at rest, but as the patient looks downward, there is a transient appearance of white sclera between the iris and the upper lid. The lowering of the upper lid, which normally accompanies downward gaze, is delayed by just a moment. Both lid retraction and lid lag are a consequence of sympathetic hyperactivity affecting the levator palpebrae superioris and superior tarsal muscles of the upper lid. It's the opposite effect of the ptosis seen in Horner syndrome, where sympathetic activity to the eye is impaired. Although lid retraction and lid lag are frequently included in descriptions of Graves' disease, unlike other ophthalmological manifestations of Graves', these are not specific to that diagnosis. To test for lid lag, simply observe the patient with his or her eyes in the neutral position, then have them look up and then down, watching if a section of sclera becomes briefly visible directly above the iris as the patient looks downward. I'm going to return to the complete list of physical findings of hyperthyroidism for a moment. From a statistical standpoint, the physical exam is more helpful in either ruling in or ruling out hyperthyroidism than it is in hypothyroidism. First, the vast majority of hyperthyroid patients have palpable thyroid glands. Thus, a normal gland size on exam argues strongly against the diagnosis. tremor and tachycardia are also relatively consistent findings whose absence would argue against the diagnosis. The findings which are most specific and which argue most in favor of a diagnosis of hyperthyroidism are lid retraction and lid lag. You probably noticed some strong parallels between the findings of hypo and hyperthyroidism. I'm going to highlight them because remembering that the two diagnoses have many opposite findings will help to remember each's presentation. When comparing hypothyroidism to hyperthyroidism, we see there is bradycardia versus tachycardia, hypotension versus hypertension, slow mentation versus psychomotor hyperactivity, slow low-pitched speech versus pressured speech, hyporeflexia versus hyperreflexia, cool dry skin versus warm moist skin, and last, coarse hair versus fine abundant hair. I'm going to conclude the video with a discussion of some notable physical findings that are specific for Graves' disease, which is the most common cause of hyperthyroidism in the US. The first is Graves' ophthalmopathy, which is seen in about 50% of Graves' patients. This is not one specific finding, but rather a constellation of related findings. The most well-known of these is exophthalmos, also known as proptosis. In exophthalmos, the eyes are literally pushed forward out of the orbit on account of fluid accumulation in the retroorbital space. The distinction between this and lid retraction, which is not specific for Graves', is much easier done from the side than from the front of the patient. Other findings of Graves' ophthalmopathy include lid and periorbital edema, limited eye movements, and something called compressive optic neuropathy. Symptoms of ophthalmopathy include the subjective impression that the eyes look different, irritation, excessive tearing, retroorbital pain or pressure, and in severe cases, visual loss. The visual loss, which is attributable to the optic neuropathy, is usually of such insidious onset and slow progression that patients may not even recognize it's happening during its earlier stages. Examination of the eyes in patients with Graves' disease should also include an assessment as to whether the upper and lower lids can close completely, as failure to do so will place the patient at a higher risk of corneal dryness and ulceration. The suspected pathogenesis of Graves' ophthalmopathy begins with the TSH receptor antibodies activating T cells, which release certain cytokines. These cytokines trigger fibroblasts to secrete glycosaminoglycans, which accumulate in the extraocular muscles and retroorbital tissues. This increases the oncotic pressure in those locations, which leads to fluid accumulation and forward displacement of the eye. The second physical finding, which is more specific for Graves' disease, is infiltrative dermopathy, which is seen in just 5% of Graves' patients. It is also known as thyroid dermopathy and pretibial myxedema. This consists of bilateral, asymmetric plaques or waxy induration, usually on the shins. The pathogenesis appears to be very similar to the ophthalmopathy. An issue raised earlier in the video is the potential confusion surrounding the use of some of these terms. For example, it's common to hear clinicians refer to this finding as pretibial myxedema, yet the term myxedema by itself is a historical synonym for hypothyroidism. Adding to the confusion is the fact that this entity of pretibial myxedema has been uncommonly described in both hypothyroid and euthyroid patients as well, and I've even heard people refer to any lower extremity edema in a patient with hypothyroidism as pretibial myxedema, irrespective of whether the type of edema seems remotely consistent with this diagnosis. Now, I won't pretend to know the history behind the confusing terminology, but I will recommend avoiding the term pretibial myxedema in favor of either infiltrative or thyroid dermopathy when associated with hyperthyroidism, and just referring to it as plain old edema in any other context, with the one qualifier as to whether or not it is pitting. That's the end of this video on the physical diagnosis of thyroid disease. If you enjoyed it, please don't forget to like it or share it, and feel free to leave questions below. Lastly, if you haven't already seen them, you may find my other videos on thyroid disease interesting as well. Today, I will be discussing thyroid function tests. The learning objectives will be first, to be able to describe the general structure and function of the hormones involved in thyroid gland regulation. Second, to be able to diagram the relationship between the thyroid hormones. Next, to use thyroid function tests to diagnose the 4 general categories of thyroidal illness. And last, to list non-thyroidal conditions which can affect TFTs. TFTs can be a confusing topic for a number of reasons. Their interpretation superficially seems like it should be incredibly easy, and for the majority of patients it is. However, a significant minority of TFTs don't conform to what logic suggests, for reasons I'll discuss. Also, the biosynthesis of thyroid hormone is unusually complex, but as most of the synthetic steps are of minimal clinical relevance, I'll be covering only the most important aspects. Finally, even the terminology surrounding TFTs is confusing. While the term thyroid hormone generally refers to one of 2 specific and nearly identical compounds, there are nevertheless a total of 4 hormones involved in the process. I'll briefly review each. The first is thyrotropin releasing hormone, or TRH. TRH is a tripeptide amide, which essentially means it's composed of 3 amino acids. It's formed in the hypothalamus and travels to the anterior pituitary via the hypothalamic hypophyseal portal system. The primary effect of TRH is to stimulate release in the pituitary of the next hormone in the pathway, TSH. Another effect of TRH, which won't be discussed further in this particular video, is to stimulate secretion of prolactin. Now, TSH, known formally as thyroid stimulating hormone, as well as thyrotropin, is a glycoprotein. It has a number of different specific effects, all of which are focused on increasing the physiologic actions of thyroid hormone. These are to increase the release of preformed thyroid hormone, to increase the rate of thyroid hormone formation, and to increase the size and number of thyroid cells which produce that hormone. Next, let me talk about the true thyroid hormones, that is, those hormones which are actually synthesized and released by the thyroid gland. They are almost universally called T3 and T4, though formally are triiodothyronine and thyroxine. As mentioned a minute ago, the biosynthesis of T3 and T4 is very complicated, but requires tyrosine and iodine. The tyrosine used for thyroid hormone is actually stored as a glycoprotein called thyroglobulin, each molecule of which has about 70 molecules of tyrosine, and the thyroid hormone is actually synthesized while still attached to the larger thyroglobulin, and remains so until it is secreted. The thyroid gland is relatively unique among endocrine organs in its ability to store large amounts of preformed hormone. This can become relevant in diseases such as Hashimoto's thyroiditis, an autoimmune-mediated destruction of the thyroid gland, which can transiently result in hyperthyroidism due to abrupt release of hormone. In normal physiologic conditions, in response to TSH, the thyroid secretes predominantly T4 along with a small amount of T3. The ratio of T4 to T3 is about 90% to 10%. After they're released, over 99% of the thyroid hormones are bound to plasma proteins in the circulation. The predominant one is called thyroxine binding globulin, or TBG, Some is also bound to albumin, as well as a protein called transthyretin, so named because it's responsible for the transport of thyroxine and retinol. Only the tiny, free, unbound form of thyroid hormone is physiologically active. The effect of protein binding is clinically important because changes in the concentration of thyroxine-binding globulin can affect the concentration of unbound hormone. For example, in steroid use and in cirrhosis, less of thyroxine-binding globulin is produced, resulting in a higher proportion of free hormones. The opposite effect occurs during pregnancy, in which the liver produces higher than normal amounts of thyroxine-binding globulin. Now, despite the fact that the thyroid secretes much more T4 than T3, the biological activity of T3 is much greater than T4. The peripheral tissues convert some of the relatively inactive T4 to the relatively active T3, as well as some to the completely inactive reverse T3, also known as RT3. In fact, some recommend considering T4 more of an inactive prohormone, and T3 really the only proper thyroid hormone. What do T3 and T4 do? They have the greatest diversity of actions of any hormone. Their primary effects are first, to increase the basal metabolic rate, which results in increased heat generation and oxygen consumption. Second, they sort of rev up metabolism, specifically increasing gluconeogenesis, glycolysis, glucose absorption from the GI tract, lipolysis, and protein turnover. Next, they stimulate bone maturation and growth. And their last major effect under normal physiologic conditions is to increase cardiac output by increasing both the heart rate and contractility. You may have noticed that many of the physiological effects of the thyroid hormones are similar to those from the activation of the sympathetic nervous system, and there may be interactions between the two which are not yet understood, explaining why beta blockers are a commonly employed treatment for some manifestations of hyperthyroidism. I'll now move on to discuss how thyroid hormones are regulated, which will partly be a visual representation of what was just covered. It begins in the brain at the hypothalamus, where TRH is released into the hypophyseal-portal system to be delivered directly to the anterior pituitary, where it stimulates TSH release. And TSH, released into the systemic circulation, travels to the thyroid, where it stimulates, among other things, the formation of predominantly T4 from thyroid globulin and iodine. T4 travels in the bloodstream largely bound to thyroxine-binding globulin, and when it reaches certain peripheral tissues, it's converted to T3 by an enzyme, or more accurately a collection of very similar enzymes called deiodinases, which, as their name implies, can add or remove an iodine atom from a molecule. There are actually a number of different names for these enzymes in medical textbooks and in the literature. One of the more common alternate names is 5'-iodinase. Now, not all of the T4 gets converted to T3, as some also gets converted into the molecule reverse T3, which, as I said before, is inactive. Both active T3 and reverse T3 only differ in which of the 4 iodine atoms were removed by the enzyme. Normally, there's about a 1-to-1 ratio of T3 to reverse T3 that is produced. However, pregnancy, fasting, hepatic and renal failure, and beta blockers all result in preferential conversion to reverse T3, thus decreasing the amount of active hormone. There are a number of important negative feedback mechanisms in this pathway. First, the thyroid hormones themselves exert negative feedback on the hypothalamus and pituitary to reduce secretion of TRH and TSH respectively. So, for example, if TSH starts to get too high, this leads to higher levels of T3 and T4, which leads to greater inhibition of TSH. Thus, the system can keep TSH and thyroid hormones within a specific window. In addition to hormonal negative feedback, there are a few others as well. For example, both physiologic and emotional stress can inhibit TRH and TSH, which is a likely contributor to the euthyroid 6 syndrome, to be discussed in a few minutes. In addition, exposure to cold temperature appears to inhibit TRH, though the clinical significance of this in humans appears to be low. The final point to bring up with this diagram concerns the two possible effects of an acute iodine load on the actions of the thyroid. The first possible effect is called the Wolff-Chaikoff effect, which is a reduction in thyroid hormone levels seen after an acute iodine load, which presumably evolved as a means to prevent hyperthyroidism in response to being suddenly provided a high amount of substrate. This effect explains both the hypothyroidism seen by some patients after starting the iodine-containing antiarrhythmic medication amiodarone, as well as the use of high-dose iodine after nuclear emergencies, as it will prevent uptake of radioactive iodine from the atmosphere. The second possible effect of an acute iodine load is called the Jod-Bastow effect, which is stimulation of the thyroid gland's production of hormone. Unlike the Wolff-Chaikoff effect, which can be seen in patients with completely normal thyroids, the Jod-Bastow effect is only observed in patients with pre-existing thyroid pathology. A typical scenario occurs when the patient with a goiter and hypothyroidism from chronic iodine deficiency moves to an area where iodine is abundant in the diet. It can also be seen in patients with a multinodular goiter or Graves' disease who has started on amiodarone. If you feel confused by these two seemingly contradictory effects, don't worry, you're not alone. Luckily, with the exception of amiodarone use, these effects come up pretty uncommonly in routine clinical practice. Okay, well now I'm finally going to get to discuss what you've probably been waiting for, the actual thyroid function tests, or TFTs. TFTs are complicated due to the variety of substances that can be measured and the variety of specific assays that different labs can use. The only three tests which are commonly checked are TSH, free T4, and to a lesser extent, free T3. We typically only order T3 when we are specifically concerned about hyperthyroidism because it will be more sensitive. Based on our current understanding of thyroid disease and current lab technology, TSH, free T4, plus or minus free T3 are more or less the only choices within the domain of thyroid function tests that you will ever need to order or interpret unless you become an endocrinologist, in which case there are a few more that may come up from time to time. Some of these other tests, which are sometimes commercially available for clinical purposes and sometimes used only for research, include the following: total T4 and T3, and something called the T3 resin uptake. Together, these tests could be used to estimate free T4 and free T3 via a calculation called the free T4-T3 index. Luckily, with the relatively recent wide availability of free T4 and T3 tests, these others are no longer necessary. Another rarely ordered test is the reverse T3. It was once in vogue as a means to distinguish true thyroid disease from TFT abnormalities caused by non-thyroidal illness. Although physiologically this use seems to make sense, its usefulness has not panned out, and it's now phenomenally rare for a conventional doctor to check one. Having said that, reverse T3 has become very popular among doctors and other providers working more on the fringes of medicine, where they often market it as the critical hormone your own doctor won't tell you about, as if endocrinologists somehow make more money by intentionally not diagnosing thyroid disease. Next is TRH. I honestly don't know if the fact it's so rarely ordered is because it's not available, not validated for clinical use, generally not helpful, or all three. There's also thyroxine binding globulin, which I've never seen ordered on a patient. And last is thyroglobulin, which actually has a very important, though uncommon role in following differentiated thyroid cancer. Since thyroglobulin is only produced by thyroid follicular cells, having detectable levels in the serum is indicative of residual thyroid tissue being present. Thus, if a patient has had the thyroid gland removed entirely as part of the treatment of thyroid cancer, but still has detectable thyroglobulin, it is suggestive of recurrent or metastatic disease. So if TSH, free T4, and free T3 are the only tests which are typically used to diagnose thyroid pathology, and free T4 and T3 typically trend together, it should be pretty easy to interpret TFTs. Well, here's a basic summary. The most common scenario is for TSH to be high and thyroid hormones to be low. That occurs in primary hypothyroidism, meaning there is something wrong with the thyroid gland itself. If the gland is diseased and not producing the hormone, there's less negative feedback on the hypothalamus and pituitary, leading to the secondary increase in TSH. A less common combination is a low TSH and high hormones, as seen with primary hyperthyroidism, including the situation of excess exogenous thyroid replacement. Much rarer combinations include low TSH and low free T4 and T3, which is referred to as central hypothyroidism, in which the problem may be in the pituitary or theoretically the hypothalamus. And last is something called secondary hyperthyroidism, in which there is a TSH producing tumor somewhere. So interpretation of TFTs doesn't seem so bad, does it? 4 combinations, 4 general diagnostic categories. Unfortunately, in a significant minority of patients, it can be substantially more challenging on account of the effect of non-thyroidal conditions on TFTs. TFTs can be affected by non-thyroidal conditions for a variety of reasons. There could be transient acquired pituitary dysfunction and critical illness, an alteration in the level of thyroid bonding globulin, an increase in circulating free fatty acids which displace thyroid hormone from thyroxine binding globulin, decreased peripheral conversion of T4 to T3, and an altered ratio of T3 to RT3. The net consequence of these potential effects may be some combination of low TSH, either low or high free T4, low free T3, and high RT3. The abnormal TFTs due to non-thyroidal illness is often referred to as either euthyroid sick syndrome or sick euthyroid syndrome. Common causes of euthyroid sick syndrome include pregnancy, any critical illness, liver disease, renal disease, malnutrition, and various medications. Let's relook at how to interpret TFTs, keeping in mind euthyroid sick syndrome, as well as a few other diagnoses. And this time let's have a column and row for a normal TSH and normal thyroid hormones. First, the obvious. Now the most common scenario, other than everything being normal, is still high TSH and low T4 plus minus T3, which is consistent with just primary hypothyroidism. There isn't really anything else that commonly causes that pattern. In the event that TSH is low and T4 and T3 are high, that's still consistent with primary hyperthyroidism, but it's also consistent with euthyroid sick syndrome, particularly if the free T4 is high but free T3 is low. If everything is low, it can be due to either central hypothyroidism as before, as well as euthyroid sick syndrome. If everything is high, it can still be due to secondary hyperthyroidism from a TSH-producing tumor. It can also be due to a very rare inherited disorder of thyroid hormone transport or hormone metabolism. Now, if the thyroid hormones are normal but TSH is not, we have a category of thyroid disease called subclinical hyperthyroidism or subclinical hypothyroidism. I'm not a huge fan of the terms, since usually subclinical means without symptoms, but in this case the diagnosis is essentially based just on lab tests. I suppose the patient is presumably not symptomatic if thyroid hormone is in the normal range, since that's the final mediator of thyroid function, but the term still feels a little misused to me. In addition, a low TSH with normal T4 and T3 can also be from euthyroid sick syndrome. A high TSH with normal T4 and T3 can occur during the recovery phase of euthyroid sick syndrome. A normal TSH with low T4 and T3 can be from euthyroid sick syndrome, and a normal TSH with high T4 and T3 is sometimes seen in acute psychiatric illness. And various drugs, most notably amiodarone, can cause almost any pattern of TFT abnormalities. So as you can see, interpretation of TFTs can become far more complicated if a patient's results don't fall neatly into one of the 4 classic patterns previously shown. When it comes to ordering TFTs, the selection of tests is very straightforward. Remember, unless you are testing for something highly unusual, only worry about TSH, free T4, and free T3. If you have a low suspicion for thyroid disease and the patient is acutely ill, consider deferring TFTs until the patient's better. It can be very difficult to sort out euthyroid 6 syndrome from true thyroid pathology in acutely ill patients. If the patient is not acutely ill, check the TSH by itself first. If it's normal, consider yourself done with no further testing. If it's high, check a free T4 to distinguish hypothyroidism from subclinical hypothyroidism. If it's low, check a free T4 and free T3. If the free T3 is elevated, it's consistent with hyperthyroidism. If it's normal, the patient likely has subclinical hyperthyroidism. If there is high suspicion for hypothyroidism, check a TSH and free T4. And if there is a high suspicion for hyperthyroidism, check a TSH, free T4, and free T3. You could ask, if we always check a T3 when hyperthyroidism is suspected, why in the world do we bother with a T4 at all? That's a good question. I don't really have a good answer for it. I don't think I've ever seen a T3 ordered without a T4, but I'm not positive a T4 is actually always necessary. I'm going to end the video with a discussion of 3 more tests which aren't technically thyroid function tests, though they are logically included with this topic. These are the anti-thyroid antibodies. The first 2 of these antibodies are anti-thyroglobulin antibody and anti-thyroid peroxidase antibody. Thyroid peroxidase is an enzyme involved in the synthesis of thyroid hormone. At least one of these is seen in almost all cases of Hashimoto's thyroiditis, the most common etiology of hypothyroidism. The last category of antibody is anti-TSH receptor antibody, of which there are 3 subtypes: stimulating, blocking, or neutral. Graves' disease, a common cause of hyperthyroidism, is due to stimulating anti-TSH receptor antibody, while various anti-TSH receptor antibodies can be seen in different stages of Hashimoto's. Measurement of these antibodies is not always needed for making the associated diagnosis if the history and exam strongly favor a particular diagnosis already. However, if the history or exam is inconsistent with a common etiology of either hypo or hyperthyroidism, or if there is concern about confounding euthyroid 6 syndrome in a critically ill patient with symptoms or signs consistent with thyroid disease, checking antibodies can be helpful. That concludes this video on thyroid function tests and their interpretation. If you found it interesting or useful, please remember to like and share it.
Understanding your thyroid function tests. In this presentation, we will talk about the free T4, free T3, and TSH blood tests which are used by your providers to understand whether your thyroid gland is functioning in a normal fashion or whether an overactive or underactive gland may be present. When we talk about the thyroid, we actually talk about 2 glands. The thyroid itself is a bow tie or butterfly shaped gland that sits at the base of your neck. In addition, we also must talk about the pituitary gland. This is a small gland that is located in the base of the brain. The pituitary gland is important because it monitors and regulates the activity of the thyroid. It regulates the thyroid through the production of a hormone called thyroid stimulating hormone, which we abbreviate TSH. As the thyroid stimulating hormone floats around in the bloodstream, it reaches the thyroid where it is necessary for the normal growth and maintenance of the gland. In addition, it also stimulates the gland to produce thyroid hormone. There are 2 main forms of thyroid hormone in your blood. One is called T4, the other is called T3. As the thyroid hormone is floating around in the blood, it passes back through the pituitary, which determines whether the amount of thyroid hormone in the blood is correct for you or not. In response, it'll either put out more or less TSH in an attempt to regulate the amount of thyroid hormone which is being made. If you think about your pituitary gland like a thermostat, and your thyroid like a furnace. The relationship between the pituitary and the thyroid follows this same model. Just as the thermostat senses the temperature of the air in your home and then signals the furnace to put out more heat if it's needed, your pituitary gland senses the level of thyroid hormone in the blood and then through thyroid stimulating hormones signals the thyroid to put out more hormone if it is required. Another way we can think about this relationship is to think about the thyroid hormone and the TSH being like children sitting at opposite ends of a teeter-totter. When all of their values are normal, the hormones then will be in balance with one another. In hyperthyroidism, there is an excess production of thyroid hormone. This extra thyroid hormone reaching the pituitary causes it to diminish its production of TSH in an effort to decrease further thyroid hormone production. This is analogous to when you're driving your car. If you see that you're over the speed limit, you do not necessarily have to apply the brakes, but instead you can let your foot up off the gas to allow the vehicle to slow down. There is no brake on the system between the pituitary and the thyroid, so the only thing the pituitary can do is to decrease its production of TSH in an effort to slow the production of thyroid hormone. If we return to our teeter-totter analogy, it makes sense that as the T4 and/or the T3 levels increase, that the TSH level would decrease. It is often confusing to patients when their providers tell them that their thyroid gland is overactive because the thyroid hormone level that they measured was low. In this situation, the provider is referring to the TSH. The TSH is typically the test that is used by providers in order to screen for thyroid disease. So the finding of a low TSH value would be consistent with your having an overactive thyroid gland. Now let's consider hypothyroidism. In this situation, there is a decrease in the production of thyroid hormone by the thyroid gland. In turn, that decreased production is perceived by the pituitary, which responds by increasing the amount of TSH that it produces in an attempt to drive the thyroid to produce more hormone. If we return to our teeter-totter analogy, we see that as the T4 and T3 levels decline, that the TSH side of the teeter-totter will rise. Again, when your doctor screened you for your thyroid condition, they may have commented to you that they thought the gland was underactive because of an elevation of the TSH. In summary, the T4 and T3 are the primary hormones that come out of the thyroid gland. The TSH is the hormone made by the pituitary that reflects the pituitary gland's opinion on the adequacy of the level of thyroid hormone in your blood. As we see in this teeter-totter, when all of those values are normal, everything is in balance and the thyroid is functioning correctly. In hyperthyroidism, as the T4 and T3 end of the teeter-totter go up, the TSH level declines. In hyperthyroidism, the excess hormone causes the pituitary to decrease the production of TSH in an attempt to decrease the production of thyroid hormone by the thyroid gland. Finally, in hypothyroidism, as the level of T4 and T3 in the bloodstream go down, the level of TSH goes up. Again, the elevation of the TSH is an attempt by the pituitary gland to signal the thyroid to increase its production of thyroid hormone to make up for the low levels of thyroid hormone that it senses in the blood. I hope this brief overview of thyroid function tests has been helpful. If you have any questions, please feel free to contact our office at the number on the screen. Thank you very much.